Good morning. This is Dr. John Bennett broadcasting from Miami, home of InternetMedicine.com, with a new studio, the Medical School Safari, run by a medical student from Zambia, Dawin, and he's going to talk about portal hypertension today. But first, we're going to introduce the panelists before I turn it over to Dawin. Hello, Danny. Could you please introduce yourself? Unmute and just introduce yourself. Danny, unmute.
Okay, yeah.
There you go.
Thank you so much. My name is Danny Kambode. I'm a fifth-year medical student from Zambia, CBU,
Okay.
Copperbelt University.
Welcome, Danny. Okay, Miss Omi, are you there?
Hi, good
Hi.
afternoon. Yes, this is Naomi here, Miss Naomi. I'm a medical student, 5th year at the Copperbelt University in Zambia.
Okay, welcome, welcome.
Thank you.
I don't know if you want to use your camera, but do you have a camera, Naomi, or no? No.
Oh, I do have a camera. I'm gonna turn it on soon.
Okay, okay. Now, if you have a problem, one thing I neglected to mention, if you have a problem with bandwidth, in other words, if you don't have a strong internet signal, you can turn your camera off because that saves bandwidth, okay? Okay, John M., could you please introduce yourself? Sometimes we have a problem introducing, that's okay, we'll get used to it. Laban, are you there? This happens to win. Okay, Samuel, are you there? Could you please introduce yourself?
Hello, my name is Samuel. I'm a 4th-year medical student at the Copperbelt University from Zambia.
Okay, welcome. Welcome. Agnes, are you there? Welcome, Samuel. Agnes, are you there? Okay, and Agnes is not there. Okay, Dawin, it's all yours, and thank you very much. And please introduce yourself before you start your presentation. Thank you.
All right, so I'll introduce myself properly. Let me go to Facebook Live. So I'm going to turn on my Facebook Live.
Okay.
That's why I'll be doing the presentation from here. So I'm going to share my screen.
Okay. Now this is new here. We're trying this. We're experimenting. Okay, there we see the board. And you're going to start the video.
All
okay,
right.
Great.
Thank you very much. Hi, everyone. I hope we are fine. So my name is Dawin Sichimba. We're starting this new program, which we're going to be running on Facebook Live as well as on Zoom. Then later on, the videos are going to be made available on YouTube. So I'm Dawin Sichimba. I'm a medical student at Copperbelt University. So we want to start this program called Medical School Safari, where we're going to be discussing a number of topics related to medicine. All right. So I'm going to portal hypertension. That is the topic for today. And I hope we are going to learn one or two things in this topic. All right. So start with definition. Okay, portal hypertension. Now, the first thing that we need to understand, even before I come to the definition itself, is that when we talk of the word portal there, all right, usually portal, it is referred to a system where veins go to another organ before they take blood back to the heart. So the normal way is that after blood goes to a particular organ, in this case, the gastrointestinal system. So after blood goes to the gastrointestinal system, ideally it's supposed to go back to the heart, straight to the heart, rather join into the major vessels and go back to the heart. But in this case, when we have a portal circulation system, it means that blood is first going to another organ, and then it joins into the main vessels, and then it goes back to the heart. All right. Then when we say hypertension, it simply means a rise, or rather a consistent and constant rise in blood pressure above a certain level, or rather a certain limit that is set. Now, in this case, since we're saying that we're talking about portal hypertension, specifically hepatic, all right? Sometimes you can call it hepatic portal hypertension. Hepatic is from liver, the word liver, all right? So now, when we say hepatic portal hypertension, we are talking about a rise in the blood pressure of the portal venous system above the range. Now, the normal range in the portal circulation system is 5 to 10 millimeters of mercury. All right. So in the veins that are taking blood to the liver, all right, the normal blood pressure there is about 5 to 10 millimeters of mercury. Now, once that blood pressure goes beyond somewhere around 12, if it is equal or greater than 12 millimeters of mercury, then we can say that we have a situation called portal hypertension. Okay, so portal hypertension is a rise in the portal venous pressure greater or equal to 12 millimeters of mercury. All right, now let me first of all give this particular illustration, all right, through which water is passing. Let's say maybe there's some rainfall, and then water is passing through that particular drainage. Now, if we have a lot of water, if there was a heavy downpour of rain, then we're going to have a lot of water passing through that particular drainage, or maybe let's say a river or something. There's going to be a lot of water passing through. Now, if that particular drainage is not wide enough, then what is going to happen is that water is probably going to start. So it's a similar case that we can talk about. Portal hypertension is basically related to two factors, that is vascular resistance, okay? Vascular resistance, that is in the portal circulation system. Vascular resistance as well as blood flow, okay? So by vascular resistance, we mean if there is so much resistance in the portal venous system, if there's anything that is causing resistance, or if there's so much blood going to the liver through those veins, then we're going to have what is called portal hypertension. Now, before we go into the causes of portal hypertension, I would like to just describe a brief anatomy of the portal venous system. Just a brief one, not so much into details. So we understand that from the mouth we have the esophagus, all right. Then somewhere there we have the gastroesophageal junction, and then we have the stomach. So from the stomach we have the small intestines. I'm going to draw the small intestines separately somewhere here. All right. Then somewhere there we have the appendix. Then you have the cecum. We have the ascending colon somewhere there, and then it starts. It joins into the transverse colon. Okay. Then somewhere here we also have the liver itself. And try to draw it like that, and then we also have the gallbladder. I'll try to put the gallbladder somewhere there. All right. Then, other than that, on the other side, we also have part of the transverse colon, and then you have the sigmoid colon somewhere there, and then you have the rectum and the anus there. Okay. Then here we also have the spleen. We have the spleen somewhere there. We also have the pancreas somewhere here. Let me put the pancreas maybe in green. All right. Now, I'm going to try to describe a few veins that are of interest in this case. All right. So the first one that we're going to talk about is what is called the left gastric vein. Okay. So the left gastric vein is somewhere here. It drains from part of the esophagus and lesser part of the stomach. All right. So it drains that portion of the GIT, and then it joins into the portal vein. So you have the portal vein going to the liver. By the way, the portal vein branches off into the right, the left, and the right portal vein. Okay. So the left gastric vein joins somewhere there. Okay. Then we also have the splenic vein. Okay. So from the spleen, it joins and also drains part of the greater curvature of the stomach. Okay. And then this splenic vein. Okay. It joins what is called the inferior mesenteric artery just behind the head of the pancreas. So just behind the head of the pancreas, somewhere there, that's where it is going to join the inferior mesenteric artery. Vein, sorry. Okay, so we have the vein there, just behind the head of the pancreas. It joins somewhere here. Then this one, like I mentioned, this is the left gastric vein. Okay. Then this is the splenic vein. We have the splenic vein there. Then we have the inferior mesenteric vein, which supplies, or rather, which drains blood from somewhere the last one set of the transverse colon, the O of the descending colon, part of the sigmoid colon, and up to the rectum there. Okay, so the inferior mesenteric vein is draining somewhere those regions. Okay, so all those regions are being drained by the inferior mesenteric vein. Okay, then we also have what is called the superior mesenteric vein. Okay, so mesenteric vein is going to supply, or rather, is going to drain blood from the wall of the small bowels, that is the small intestine, and the ascending colon, and the larger part of the transverse colon. Okay, so all these portions are being drained by the superior mesenteric vein. So we have this one. We have here the inferior mesenteric vein, and there we have the superior mesenteric vein. Okay. Now, briefly, that is the portal circulation, or the portal circulation system in the GIT. And by the way, somewhere there, that's why we have the hepatic vein. Okay. So after blood goes to the liver, it leaves the liver through what is called the hepatic vein. Let me put it in blue. All right. Then this hepatic vein is going to join what is called the inferior vena cava. Okay. So this one here is the hepatic vein. Then this is the inferior vena cava. All right. So now, when we talk of portal hypertension, like we mentioned, we said that portal hypertension is a rise in blood pressure in the portal circulation system. So in other words, blood pressure has risen in all these blood vessels that we have described, in the left gastric vein, in the splenic vein, in the inferior mesenteric vein, superior mesenteric vein, or even in the hepatic vein. Now, the causes, despite, no matter what the cause may be, what we should understand is that that blood pressure, it should be greater or equal to 12 millimeters of mercury. Okay. above 12 millimeters of mercury. Now, what then are the causes of this portal hypertension? Okay, so there are various causes of portal hypertension, but I'll try as much as possible probably to classify them or divide them into three major classes or divisions. Okay, so those divisions or classes of causes of this portal hypertension, we have one, what is called pre-hepatic. We have pre-hepatic causes. All right. Then two, we have what is called the intra-hepatic or simply hepatic, intra-hepatic. Then lastly, we have what is called the post-hepatic causes. All right. So when we say pre-hepatic causes, we are talking about all those causes that are taking place or anything that is affecting parts of this circulation system, but before the liver. All right. Now, the most common causes in this case is thrombosis. Okay. The most common cause of pre-hepatic causes is thrombosis. Other than that, we can also have things like congenital atresia or congenital atresia of any of these blood vessels. It could be the splenic veins, it could be the left gastric vein, or most likely it could be the hepatic portal vein itself, where we have the lumen of the blood vessel has reduced in size. All right. Then other than that, we can also have any extrinsic obstruction. Okay. For example, if there's a tumor or if there's maybe, let's say, for example, like a cancer or something, such that there's obstruction in on any of these, let's say there's compression on any of these blood vessels, then we can expect that we're going to have portal hypertension in that case. Okay. So anything that is going to cause increased blood pressure in these veins, in the left gastric vein, the splenic vein, the inferior mesenteric vein, the superior mesenteric vein. If anything causes increased blood pressure in these particular veins, then we call it as pre-hepatic causes of portal hypertension. All right. So there are several other causes. Okay. There are several other causes that we can talk about, but the most important one is on intra-hepatic. Okay. Intra-hepatic causes of portal hypertension, the most common cause, and by the way, intra-hepatic cause of portal hypertension, this is by far the most common cause of portal hypertension. And under intra-hepatic causes of portal hypertension, we have the commonest is cirrhosis. So liver cirrhosis, for whatever causes, okay, is the most common cause of intra-hepatic portal hypertension. So what is happening in this case? By the way, let me try to briefly draw the brief histology of the liver. So if you cut through the liver and look at it using a microscope, we have the functional unit of the liver, what is called the lobule. Now those are hexagonal. They look something like that. All right. Now, in the center there, we have what is called the central vein. Okay, we have the central vein in the center there. Then we also have veins in each of those corners. Then we also have an artery. Then we also have the biliary tree, the bile ducts like that. Okay. Now, inside there we have what are called sinusoids. All right. Then we have the hepatocytes. Let's say those are the hepatocytes and so on. Let's say those are the hepatocytes. Then we have branches from, now, by the way, this portion of the lobule, okay, this is what is called the portal triad. Okay, portal triad because there are basically 3 vessels there. That is the artery, okay, a branch from the hepatic artery. Then we also have the vein. All right, this vein is coming from the portal vein, the hepatic portal vein. Then we also have branches of the biliary, rather the bile duct. So what happens is that from the hepatic portal veins, from there blood is able to go to the central vein through the sinusoid like that. Okay, so we can see that there are 2 blood supplies to the liver. That is the hepatic blood, or rather the portal blood, that is from the hepatic portal vein, and that from the arteries, that is from the hepatic artery. Okay, so but by far up to about 70% of blood which is going to the liver, okay, up to about 70% of blood going to the liver is from the hepatic portal vein. All right, but then the rest of the blood, that is about 30%, is coming from the hepatic artery. Now that is important because blood has to move from the GIT to the liver, so that all other processes, in case you ingested something that is poisonous, then that poisonous substance can be detoxified. All those products of digestion can also be assimilated and be utilized by the body in the liver, and so on and so forth. All right. So now, then at the same time, the liver also requires oxygenated blood. Remember, by the time blood is passing through the GIT, through the stomach, the spleen, the small and the large bowels, by the time it's passing through there, most likely much of the oxygen would have been used from there. Okay, so then there's need of another blood supply to the liver, that is from the hepatic artery. So that's how come we are having another branch there. So basically that is what is happening. That is the histological picture of the liver. Okay, so in the case of intrahepatic causes, when we have cirrhosis, it means that there's fibrosis, or rather scarring, in this particular portion of the liver. In this part of the liver, we have scarring. Okay, there is fibrosis. Now, when fibrosis takes place, when fibrosis occurs, it means that much of these blood vessels, these coming from the portal vein, going to the central vein, those are going to start getting obstructed. Okay, there can also be things like hyperplasia of the hepatocyte. Okay, when there is hyperplasia of the hepatocyte, we can also start having compression of those sinusoids in the lobule of the liver. Okay, other things that can also happen is when we have conditions such as Budd-Chiari syndrome, then even when we have things like tumors, as well as myeloproliferative disorders, even disorders such as hemochromatosis, those can also be classified under intrahepatic causes. But like I mentioned, by far the most common cause of portal hypertension under intrahepatic causes is what is called cirrhosis. All right. Then under this we can also have alcoholic liver disease. Alcoholic liver disease. We can have viral hepatitis. Viral hepatitis. Okay, so all these are going to cause intrahepatic causes of portal hypertension. Okay, under post-hepatic causes of portal hypertension. All right. Now remember, there's we had the liver somewhere here. We had the liver here. Okay, and then we have from there we have the hepatic vein, which then joins the inferior vena cava. Okay, so anything from there up to the vena cava and even up to the heart can cause post-hepatic portal hypertension. Okay, so if there's, let's say, atresia of this hepatic vein, or if there's thrombosis in this particular system, in the portal vein as well as in the inferior vena cava, then we can also have portal hypertension. The other cause, the very important cause of portal hypertension, that is post-hepatic portal hypertension, is what is called right-sided heart failure. Now, in right-sided heart failure, it means that the right ventricle is not able to pump blood out into the pulmonary artery. Now, if blood is not being pumped out into the pulmonary artery, it means that it will start accumulating in the right ventricle. From the right ventricle, it will start flowing back into the right atrium, back into the vena cava, back into the hepatic vein, and into the liver, and so on. Okay, so we're going to have that kind of a chain. Okay, other causes, we can also have things like tricuspid regurgitation. Okay, so what it means in tricuspid regurgitation is that remember, the tricuspid valve is the valve that is between the right atrium and the right ventricle. So in tricuspid regurgitation, it means that blood is still able to go out through, because when blood moves from the right atrium into the right ventricle, all right, then as it is being pumped into the pulmonary artery, the tricuspid valves are supposed to close. Now, if the tricuspid valve does from the right ventricle into the right atrium and back into the vena cava and also into the hepatic vein. So such conditions as tricuspid regurgitation can also cause what is called portal hypertension. That is in the case of post-hepatic causes. All right. So, like I mentioned, there are several causes of portal hypertension. All right. But the mechanism is basically because there's increased blood flow in the portal circulation, and there's also maybe resistance in blood flow. So blood is trying to pass through, but there's resistance. Even if the amount of blood is normal, but if there's resistance, it means that blood is not going to pass through correctly. Then if we also have a lot of blood passing through, then we can also have that portal hypertension. All right. Now, what is the pathophysiology? In other words, what exactly happens in this particular case? If we have any of those conditions happening, if we have, let's say, a thrombus, okay? If let's say there's a thrombus somewhere here, let me use black there, or let me use red. Okay. If there's a thrombus that is obstructing the hepatic portal vein, all right, it means that blood that is coming from the left gastric vein will not be able to reach the liver so easily. Blood coming from the splenic vein will not also be able to reach the liver so easily. That from the inferior mesenteric vein as well as from the superior mesenteric vein will not be able to reach the liver very well. So what is going to happen is that there's going to be backflow of blood. Blood is going to start accumulating through that venous system. Okay, it starts accumulating through the venous system and so on and so forth. Now, because blood is supposed to flow, there's not supposed to be accumulation of blood in those venous veins. Then blood will start more like trying to find alternatives. Remember what I said from the beginning? If water is passing through a drainage, if there was a heavy downpour and then the drainage is not big enough, that water that is passing through those drainages will try to find alternative routes so that that congestion in that drainage is probably reduced. Okay, so when there is that portal hypertension, mostly it requires that up to about 90% of blood is redirected somewhere else for the blood pressure to reduce to normal levels. Okay, so up to about 90% of the blood, when there's portal hypertension, has to be removed from the portal circulation system so that we return to the normal level of blood pressure in that particular area. Now, so what will happen? Let's start with in the left gastric vein. Remember, I mentioned that the left gastric vein is draining blood from junction there, okay, as well as the lesser curvature of the stomach. Okay, so now if there is increased blood pressure in this left gastric vein, what will happen is that there's going to there are some tributaries of veins, okay, that eventually take blood back to the heart. Okay, so those veins, some of them, they go to join into the azygous vein, which eventually goes back to the heart. So because of that, in those small blood vessels, in those small veins, there's also going to be increased pressure in those small veins as well, and that is going to make them to start more like bulging up, and that is what is called gastroesophageal viruses. Okay, and this is the most important complication of portal hypertension. What basically because of it's associated with high mortality. Up there, we are going to have what is called esophageal viruses. Okay, so esophageal viruses, those are just engorged veins around the gastroesophageal junction due to the high pressure in those in that particular area. Okay, the other thing that is going to happen is that I'll get back to the esophageal viruses. The other thing that will happen is that we also have a splenic vein. Okay, so in the splenic vein there, blood will start going back into the spleen. All right. Now, by the way, it's not only the case of thrombosis. It could also be maybe from the heart, blood is coming back to the liver and start going back into the splenic vein and the other veins. Okay, so in the splenic vein, blood will start going back into the spleen. Now, if there's a lot of accumulation of blood in the spleen there, we're going to have splenomegaly. Okay, so we're going to have splenomegaly in that case. Then let's look at the inferior mesenteric vein. In the inferior mesenteric vein, what happens is that about the upper 2/3 of the rectum, okay, the upper 2/3 of the rectum there is drained by branches from the inferior mesenteric vein. Okay, so those branches from the inferior mesenteric vein, even at this portion, just like at the gastroesophageal junction, what will happen even in that case is that blood will start trying to look for other alternatives, other tributaries of blood vessels where blood can go. And in that case, we're going to have engorgement of blood vessels there, and it is going to result in what is called hemorrhoids. Okay, so we're going to have what are called hemorrhoids. Then, when we look at the sphero-mesenteric vein there, okay? So from the sphero-mesenteric vein, that's where we have some veins that are coming, that are draining the abdominal wall, the anterior abdominal wall, all right? So that is why we're going to have engorged blood vessels on the abdominal wall. And one of the common findings is what is called Kaput Medusa. Kaput Medusa. All right. Now, in the case of Kaput Medusa, it is specifically due to blood flowing back into the umbilical vein. Okay. So blood that is taking, I mean, the vein that is taking carrying blood from around the umbilicus. Then we're going to have those blood vessels. Its branches are going to get engorged and are going to have what is called Kaput Medusa. All right. The other thing that is going to happen, because there is so much engorgement of blood in that region, in the abdomen, all right, fluid is going to start oozing out of the blood vessels from the capillaries and so on, and you're going to have what is called ascites. Okay, we're going to have what is called ascites. Now, when there's ascites, what we expect is that there can also actually be things like spontaneous bacterial peritonitis. Okay. Now, the other thing that happens in this case is that because blood is trying to find a way, blood, by the way, is not being more like purified by the liver. All right, it's not being purified by the liver as it should. All the detoxification and so on is not taking place because the liver is probably damaged and so on. Okay, so through those alternative routes, which blood is using, let's say for example, at the gastroesophageal junction there, blood is able to join into the azygous vein. From the azygous vein, it will go into the right atrium. From the right atrium, it goes into the right ventricle. Right ventricle, from right ventricle to the lungs through the pulmonary artery. From there, it comes back into the left ventricle, and blood then is pumped out to other parts of the body. Now, remember, that blood has not been detoxified by the liver. Okay, so because of that, if blood goes to parts such as the brain, then we are going to have what is called hepatic encephalopathy. So this is number 6. We have hepatic encephalopathy. All right, we're going to have hepatic encephalopathy. Now, so these are some of the things, basically, when it comes to pathophysiology, these are some of the things that are going to result from this portal hypertension. Okay. Now, when it comes to clinical presentation, okay, how do patients with portal hypertension present? What are some of the things that are going to tell us that this patient, a particular patient, has portal hypertension? Now, clinical presentation in this case is highly dependent on two things. Highly dependent on two things. That is one, the cause of portal hypertension. All right. And then 2, the complications, associated complications of portal hypertension. Okay. So when we are assessing patients who we suspect to have portal hypertension, attention should be drawn to making sure that we see the underlying cause of portal hypertension, number 1, okay? Because we need to know, we cannot treat portal hypertension on its own, but we can treat the cause. What is the cause of this portal hypertension? Okay. So when we're assessing the patients, we need to look at the cause of portal hypertension. Then we also need to look out for the complications. Okay. So what are the complications of this portal hypertension? So for example, in the case of causes, all right, remember some of the causes that we mentioned under portal hypertension. We talked about cirrhosis. Okay, we talked about family diseases such as hemochromatosis, familial disorders, hemochromatosis. Okay, we talked about things such as hepatitis. That could be B and C. Okay. Then we also talked about alcohol. Okay, alcohol. So let's talk about it in terms of these cases. Now, on clinical presentation, remember we're talking about two things, that is on history and on examination. Okay. So on history, what can we look out for in terms of the causes of portal hypertension? Now, we have to look at things such as history of jaundice. The patient may tell you okay, that they have noticed things associated with jaundice. For example, there can be dark urine, okay, there can be pruritus, okay, that is itchiness on the skin. We can also have, these patients can also have things such as a history of abnormal sexual behavior. Okay, so abnormal sexual behavior is going to predispose these patients to contracting conditions such as hepatitis B or C. Okay, so if these patients have lived a promiscuous kind of life, then they are at risk of contracting this kind of disease, which in turn is going to cause portal hypertension. Okay, so we can try to find out from these patients how has their sexual life been. Okay, we can ask about history of alcohol abuse. Okay, those heavy alcoholics, they can develop alcohol liver disease. Okay, then we can also ask about, let's say, things like history of blood transfusion, other blood products, as well as IV drug use. Okay, so those who inject themselves with drugs, drugs of abuse, they are also likely to contract such kind of diseases. Blood transfusion, although with advanced screening tests, mostly there are quite lower chances of someone contracting hepatitis B and C through blood transfusion or other blood products. Otherwise, it is still a possibility, but due to advancement in the screening methods, such cases are much less. Okay, familial history of liver disease such as hemochromatosis. Okay, we can also try to ask, are there any family members that have had any liver disease? Okay, then on complications, like I mentioned, we have things like we can have things like varices, esophageal varices. Okay, so there could be history of vomiting up blood. Okay, vomiting up blood, rather that is hematemesis. Okay, they can have difficulty in swallowing. Okay. Then on this one, we can also have things like melena. Okay, because blood from the esophagus, if those varices are bleeding, okay, then blood from the esophagus can move down and get mixed with fecal matter, and fecal matter will start looking blackish or quite dark. So that is melena. Okay, we can also have things like hematochezia. Okay, that is fresh blood in the stool. Okay, then remember, this is they are bleeding. Okay, so if they are bleeding, they can also present with symptoms of anemia, because these patients are bleeding. Okay, so these patients can also be having fatigue. Okay, or tiredness, dizziness, and so on, because they are anemic. Okay. Other complications that we talked about, such as hepatic encephalopathy. Okay. So in this case, when we are taking history for patients that we suspect may have portal hypertension, we need to also ask questions concerning hepatic encephalopathy. So now, this one, we can talk about things such as confusion. Okay, so a patient presents with confusion. Okay, they can also present with things like amnesia, that is memory loss. Okay, disorientation, or other same as confusion, and so on. Okay, they can also have convulsions may also be a common feature in this patient. So when we look at this, we find that we are trying to assess what could be the cause and what could be the complications in this patient. Okay. Then, so we've done the history on examination. On examination, we can start, for example, from the hands. Okay. From the hands, these patients may present with things such as leukonychia and koilonychia because we are suspecting that these patients, they have liver disease. Okay. And by the way, other than under the causes, we talked about things like right-sided duct failure. Okay. So it could be right-sided duct failure that is causing this portal hypertension. So you can also try to look at the symptoms of right-sided duct failure. So these patients can also present with things like difficult breathing. They can present with things such as difficult breathing on lying down, nocturnal, paroxysmal nocturnal dyspnea, and so on. Okay. So I was talking about on examination. Okay. Starting from the hands, you can look at things such as on the fingers. They can present with koilonychia or leukonychia. Okay. These patients can present with palmar pallor because they are bleeding. Okay. The other cause of bleeding in this case, other than the viruses bleeding, are those variceal hemorrhage. The other cause of bleeding could be because, remember, the liver is probably damaged in this patient. Okay. So even clotting factors and so on, those are deranged as well. So the bleeding, other causes of bleeding could also be due to clotting factor deficiencies. Okay. Things such as vitamin K and other clotting factors because the liver is not functioning properly. Okay. Other things that we may also see is on the fingers. Okay. I talked about palmar pallor. You can also have things like palmar erythema. Okay. You can also look at things such as tube-trans contracture. You can talk about things such as tremors. Okay. Hepatic tremors. Those are some of the things that you can see. As well as just on general examination, actually, in this patient, these patients may look wasted. Okay. They may be wasted. So they may be wasted. Now, the cause of wasting in this case could be two. One, these patients have anorexia. Okay, they do not have a good appetite, so they are not eating enough. So they are having nutritional deficiencies. Okay, even the liver itself is not processing those nutrients as it should. So these patients are going to have wasting. They are going to look wasted. Okay, then. On the pulse, we may find that the pulse of this patient is probably increased. Okay, it may be bounding and so on, depending on the cause and some of the other complications. Okay, when you look at these patients, if you look at the eyes, on the eyes, you may find that they are having conjunctival pallor. They may be having jaundice. Okay, because of the liver disease. These patients also may present because we're saying that there are things like ascites. There are also things such as splenomegaly. So we may see that this patient, their abdomen is distended because of the ascites as well as the splenomegaly. Okay. So those are some of the things that we may try to look out in these patients also on examination. So like I mentioned, clinical presentation in these patients highly depends on the cause, the exact cause of the portal hypertension. It also depends on the complications of this portal hypertension. All right. So now, from clinical presentation, let's look at how can we investigate these patients. Okay? How can we investigate these patients? What are some of the tests that should be done in these patients? Now, one of the things that can be done in these patients, remember, like just from clinical presentation, okay, from clinical presentation, we see that patients who present depending on the cause or the complications. So even in terms of trying to make a diagnosis or in terms of the various tests that we should do, we should also follow a similar order. Okay. So for example, if we suspect that the cause is let's say cirrhosis, Okay. If let's say we suspect that the cause is cirrhosis, then we can do things such as, of course, we can do full blood count. Okay. We can do full blood count. We can check for the blood. We can also do a clotting profile. Clotting profile. Okay. That is PT, PTT, as well as INR. Okay. That is thrombin time, partial thromboplastin time, and international normalized ratio. Okay. Other things that we can also look at are the liver enzymes. Liver enzymes, okay, usually AST and ALT. Okay. We may also do alcohol studies on these patients. Okay, alcohol studies on these patients. If we suspect that the cause of their liver disease is alcohol, we can do alcohol studies. All right. For example, if we also suspect that the cause in this patient is hepatitis, okay, we can also do a serology, for example, okay, serology, that is virology or virology, okay. So to check if they have either hepatitis B or hepatitis C, okay. So those are some of the things that we can do in this case. If we suspect, for example, that the cause of their portal hypertension is due to heart problems, okay, we can, that is right-sided heart failure, okay. In the case of right-sided heart failure, then we can do tests on the heart. We can do ECG, echo, even X-ray, okay, chest X-ray. We can do chest X-ray as well on this patient, okay. We also talked about the complications. We said that even our diagnosis, or rather the test that we are doing on this patient, will also depend on probably the complications, okay. Remember, already from the full blood count there, okay, from the full blood count, we can see that they are going to have a reduced HB, okay. They can also have thrombocytopenia, okay, reduced platelets, and so on, okay, because they are bleeding and because they are having nutritional deficiencies, we may see a certain type of anemia in these patients, okay. So basically, those are some of the tests that we can do. We can also do abdominal ultrasound. Abdominal ultrasound, that is specifically to check on the liver, okay, as well as those major blood vessels. We can also do Doppler ultrasound. Remember, we talked about things like thrombosis being one of the causes. If there's a thrombus, then we can also use Doppler ultrasound in this case, okay. We can also use CT scan or MRI in this particular patient. Okay, so I'll repeat this point. The clinical presentation and the various tests that we're going to do in this case, in the case of this patient, highly depends on what we suspect could be the cause, as well as what we suspect could be some of the complications in this patient. All right. So management of these patients will also follow a similar order, but of course, we need to make sure that their airways, okay, are patent, okay. We need to do, in other words, we need to do resuscitative measures. We check for their airways, we check for their breathing, we check for the circulation. We make sure that these patients are stable enough before we can even start doing any other things, doing all these tests and so on. We need to make sure that these patients are stable enough, we resuscitate them, and then we do the definitive management depending on the cause and the complications that we have found in these patients. Okay. For example, if this patient's portal hypertension is due to right-sided heart failure, okay, then we may start giving these patients some of the things that we may give these patients could be things such as diuretics, okay, because we want to reduce that backflow of blood, or rather the blood that is accumulating, the fluid overload on these patients, and so on. Okay, so it highly depends on the exact cause. Okay, the other thing that we may also probably do, because they are anemic, these patients are anemic, we may also need to give a blood transfusion. We may need to do blood transfusion. We may need to give certain vitamin supplements. All right, for example, vitamin K. If some of the causes of the bleeding is due to vitamin K deficiency, you may also need to give some of those. So the exact management will also depend exactly on the cause as well as the complications of portal hypertension. All right. This is basically about portal hypertension. Just a wrap up. Portal hypertension is refers to an increase in the portal circulation venous pressure, okay, above 12 millimeters of mercury, or equal to 12 millimeters of mercury. Okay. The exact mechanism is basically due to resistance, vascular resistance, or due to blood flow. Okay. Now, the causes are classified into three. That is pre-hepatic, intra-hepatic, and post-hepatic. Okay. By far, the most common cause is intra-hepatic causes. Okay. And under intra-hepatic causes, what we mentioned is that the commonest cause is cirrhosis. Liver cirrhosis is the major cause of portal hypertension in this patient. Then from there, we talked about the pathophysiology. All right, pathophysiology basically will involve the backflow of blood into the portal circulation system. When blood goes into the left gastric vein, there's going to be formation of esophageal varices, which are the most common and important complications of portal hypertension. Okay, and studies have shown that esophageal varices develop when what is called the hepatic portal venous pressure gradient. Okay, hepatic portal venous pressure gradient, when it goes beyond 10 millimeters of mercury. Okay, so when the hepatic portal venous pressure gradient goes beyond 10, okay, because the normal is 1 to 5 millimeters of mercury. So once it goes up to 10 and beyond, then most likely we may have patients developing esophageal varices. And studies have also shown that patients who develop, patients with a compensated liver, okay? If the liver is compensated, then the chance of patients developing these esophageal varices is about 30%. But if the liver is decompensated, the chances of them developing liver disease is about 60 to 70%. And mortality is highly increased in patients who develop esophageal varices. Okay. Then, other than esophageal varices, if we look at the splenic vein, blood will go into the splenic vein, and from there we're going to have development of what is called splenomegaly. Blood may also go into the inferior mesenteric vein, from there which goes up to the upper two-thirds of the rectum, and we're going to have development of what are called hemorrhoids. Okay, and that's why patients may also develop with, present with passing fresh blood in their stool, because maybe their hemorrhoids are bleeding, or there could be pain on passing stool, okay, because of the same hemorrhoid. Okay, then because of stasis of blood, there may be oozing out of fluid into the peritoneal cavity, and they're going to have what is called ascites. Okay, blood may also find other channels and eventually reach the brain, and that blood which is reaching the brain is not detoxified and so on. So patients may develop what is called hepatic encephalopathy. Right. So patients may also present with what is called Kaput Medusa. So we may have all those complications in these patients. Okay. Then on clinical presentations, we mentioned that it depends on the exact cause and some of the complications that may be there. Then on diagnosis or the workup, what we do for this patient in order for us to make a diagnosis will also depend on what we suspect. We need to rule out all the causes, all the possible causes of this portal hypertension. Okay. We also need to rule out some of the complications of portal hypertension. All right. So the management will also depend on what exactly our diagnosis, our definitive diagnosis is, and what some of the complications that are there. Those are some of the those are things that we're going to make sure we do for these patients in terms of management. Otherwise, what we should not forget is to do the basic resuscitative measures for this particular patient. So thank you very much for joining me in this tutorial. Until next time.
Oh, very good, Dawin. Excellent, clear presentation, and I salute you for trying the combination of Facebook Live and Zoom. Now, I don't know if the people watching are realizing this, but right now, Dawin is televising live, not only to Facebook Live, but also to YouTube, as well as the website of the studio that we built for him, Medical School Safari. I just picked that hook because most people associate Safari with Africa, and hopefully it'll get people curious, not just another lecture by a student, but a safari. We're not looking for animals, we're looking for medical facts. So I'd like to meet all you guys and hear what you have to say. And please, if you have any questions or comments for Dawin, please go ahead. Danny, do you have any comments? I'll be one of those teachers that bothers people. Hello, Danny, can you hear me okay? Yeah, go ahead, Danny. Unmute yourself.
Yes, I can hear you.
Go ahead, go ahead.
Okay, thank you. First, it's a brilliant presentation from Dawin. It was brilliant, really. But I wanted to find out, what is the role of surgery in patients with portal hypertension?
Okay. So like I mentioned, if I had to go into each of the causes and explain them and their management and so on, probably this could have taken us the whole day. But I'll try to mention the role of surgery. If, let's say, for example, the cause of portal hypertension in this case is, let's say, maybe atresia, okay? Maybe let's say of the splenic vein or the portal vein itself, all right? So if there's atresia in that case, then we may do surgery for this particular patient as a definitive diagnosis, as a definitive management, so that we correct that particular atresia that is there, or rather the narrowing of the blood vessel. So I think, I don't know if I've answered your question. So just an example, if we have atresia as the cause of the portal hypertension, then we can do surgery on this patient.
Okay, that's helpful. Thank you so much.
Clear? You can probably add something that you may think of.
No, that's fine. Thank you. I am satisfied with your answer.
Okay, sure. That's great. Ms. Omi, any questions?
Okay, that was a very brilliant and clear presentation. Thank you so much. My question
You're welcome.
On the spontaneous bacterial peritonitis that may come about to the ascites, like what is really bringing it about, and what bacteria is common to cause that type of peritonitis in those patients. And then on the management, on the investigations, if you suspect that right-sided heart failure is the one that's causing the portal hypertension, would it be okay to also add cardiac enzyme, like to test for that? Yeah.
All right. I'll start with the peritonitis. Okay. So remember, in these patients, what has happened is that there's accumulation of fluid in the abdomen. All right. Now that is going to disturb, or rather, that is going to cause a disturbance in the peritoneal cavity. Okay. Remember, there's normal flora in the peritoneal cavity. Okay. So because of increased fluid in the peritoneal cavity, then it means that there's going to be a disturbance in the normal mechanisms that are taking place. And some of the, I'm not so sure the exact bacteria that may be associated. Maybe you can assist me on that, or anyone can assist me on that one, the exact bacteria that is usually associated. But I think things such as E. coli may probably be associated with spontaneous bacterial peritonitis.
Oh, okay. All right. I'm not very sure. I would have said which bacteria, but I'm not sure which one. That's why I asked.
Danny?
No, not really. I'm not sure. Maybe if you finished another question, I wanted to clarify something. Huh?
Okay. Then on the part of cardiac enzymes, yes, cardiac enzymes on investigations, it may be important as well to do cardiac enzymes. So like I mentioned, I didn't really mention all the investigations that may need to be done, but it highly depends on the cause. So in that case, we may also do cardiac enzymes if we suspect that the cause of the portal hypertension is right-sided access. And by the way, remember, some of the causes of right-sided heart failure could also be things such as pulmonary disease, where we have what is called copulmonary. Okay, so also investigations on the pulmonary system, or rather on the lungs and so on, may also be helpful in that case. Okay, so that we see if at all the right-sided heart failure was due to pulmonary disease, and eventually that causing the portal hypertension.
Okay, thank you so much. Okay.
You're welcome. Any other additions or questions?
Yes, maybe just a quick clarity again. I was very impressed. I wanted to find out now, how does a spider nearby fit in this picture? I heard you explained about Kaput Medusa, the varices, and others, but maybe I missed the part for spider nearby. How does it? Because it's quite a common presentation also in patients with chronic liver diseases.
Yes. All right. So what is happening is that because of vascular resistance, okay, and blood flow, okay, blood will start going back into the portal venous system. Okay. Now, some of the veins that drain from the abdominal wall are branches from the inferior, from the superior mesenteric vein. So what will happen is that if there is an increased pressure in the superior mesenteric vein, it means that blood will flow back also into the veins in the abdominal wall. Okay. Now, when we talk of spider nevi, or even things such as Kaput Medusa, it looks something like this, as if there's maybe some sort of a central vein, and then there are tributaries of smaller veins like that. Okay, it's like there's a larger vein, and then there are tributaries of smaller veins, such that that larger vein is kind of congested with blood, and those small veins are also congested with blood as well. that is on the abdominal wall. Okay, so basically it is also resulting from the backflow of blood into the superior mesenteric vein, of which some of the branches, or some of the veins that are draining from the abdominal wall are also branches from the superior mesenteric vein. So I think that would be my explanation to that.
No, thank you so much.
You're welcome. I think there are probably no more questions or any additions, any clarity. Laban, are you there? Okay, so thank you very much. Dr. Bennett, back to you. I think your microphone is mute.
That's my point. We make mistakes. Like I just made them. I've been doing these for years, but I'm still making mistakes. But you know what? I'm not afraid to make mistakes.
Yes.
I'm not afraid to make
Sure.
mistakes because we're dealing with new technology here. And what this is, it's a most effective form of medical education is interactive medication. And it happens to be the most fun. I love meeting guys
Yes.
like you, and I'm sure you guys like meeting new people. And of course, there's also book learning, which is great, but also the interactive aspect of this technology that we have becoming more popular. You know, Zoom, before this COVID crisis, had 10 million per day followers, users. Now there's 200 million. It's gone up by 20, because people are at home, and I think they're finally awakening to, hey, wait a minute, let me try this video thing that I've heard about. Because you find in medicine, things change slowly. Things change very slowly. But I think after this COVID's over, which I think it will be, I think you'll find that some people that have been exposed to interactive video will continue it.
Yes.
I know that in Africa, I think has a good future because in some cases you're limited by bandwidth. However, things are going to improve slowly, not quickly, but slowly. And I think you're going to find this is a very useful. And what we did now, the panelists, Dawin and I fashioned, we do Zoom and Facebook Live at the same time, which is great because Dawin can not only answer questions from his people that text, they can ideally, I can have people like people in the panel like you guys that interact with him verbally. So they get verbal interaction and Dawin gets text interaction. So it's beautiful, beautiful. I think this combination, this hybrid combination is going to be good. And I'm looking forward to experimenting with it. Thank you, Dawin. And what is the next show?
Thank you so much, Dr. Bennett.
When is your next broadcast, Dawin? Do you have it planned, or are you going to let me know? Or?
Well, I was thinking maybe we can be having it once a week.
Sure, that's fine. That's fine.
Or maybe,
okay,
twice, but I think maybe once a week.
That's fine. Okay, just let me know the topic,
Yes.
and so that we can, you know,
Right.
part of this platform I think is promotion,
Yes.
my experience has been that a lot of people won't even know it exists unless you let them know. Let them tell them by Facebook, and you guys probably know how to use Facebook better than me. But to let people know, because if people knew about it, they might be interested and might come. So that promotion is part of it. And Facebook's a wonderful tool. I don't know if you guys use it a lot, but I'm a late comer to
It really
Facebook.
is a powerful tool.
I'm sorry, go ahead again.
Okay, so I'll let you know on the topic, probably something that may be related to the things that we're discussing today.
Okay.
We'll see which topic we can
Okay, very
pick on.
great, very good. Okay, I'm going to end the broadcast and just stay here. We can just chat. So thank you, everybody.